Dear colleagues, we introduced our study on a new method for aortic valve planimetry with high-resolution three-dimensional MRI. The severity of aortic stenosis can be assessed with Doppler echocardiography by measuring the AS jet velocity. The aortic valve area can be assessed by either the continuity equation or direct planimetry. Echo relies on the measurement of the left ventricular outflow tract, which is ovoid and sometimes difficult to accurately measure. Echo requires good imaging windows for accurate diagnosis. CMR is a complementary tool for non-invasively evaluating AS. With conventional two-dimensional Cine MR imaging, measurement errors occurs especially in heavily calcified aortic valves related to voxel size relative to the AVA, low signals in calcifications, turbulences close to the borders of the aortic leaflets, and irregularities in the shape of the stenotic orifice. And it is difficult to depict the exact phase and location of the maximal systolic opening on two-dimensional Cine images placed perpendicular to the valve flow as the valve is continuously moving during the cardiac cycle. We hypothesized that the novel application of aortic planimetry with high spatial resolution three-dimensional MR images would provide faster and more reliable information on aortic valve planimetry than 2D Cine MR images. The aim of this study was to test whether high-resolution 3D MR image acquisition with single breath hold SSFP sequences could facilitate a reproducible and accurate evaluation of AVA. We performed a prospective study in 142 consecutive patients who underwent CMR and echocardiography with varying degrees of AS at our institution. CMR was indicated in those patients for accurately assessing LV and aortic valvular function, the degree of myocardial fibrosis, and stress myocardial perfusion. 3 patients were excluded because of poor image quality, leaving 139 patients for the analysis. For comparison, we included 21 asymptomatic controls. All patients underwent cardiac MRI during repeated breath holding using a 1.5T scanner with a 32-channel phased array receiver coil. High-resolution 3D SSFP images were acquired within a single breath hold during mid-systole. The imaging parameters are shown. Figures show CMR image acquisition scheme for three-dimensional planimetry. Image acquisition duration was 190 milliseconds. Data were acquired at 107 to 297 milliseconds after the R peak during the systolic phase. We also performed balanced SSFP Cine MRI and velocity-encoded Cine MRI at 3 levels of the aortic valve. SSFP was used to obtain 2D images in the prescribed planes during multi-phases throughout the cardiac cycle. Cine images were acquired in 3 short-axis views covering the AVA from the left ventricular outflow tract to the ascending aorta at 6 mm intervals using a segmented SSFP sequence. To produce an SSFP Cine image throughout systole and diastole, the images were obtained over several cardiac cycles in multiple breath holds. Acquisition parameters for the Cine images and Vanc imaging were as follows. Figures show comparison of image prescription of 2D and 3D planimetry sequences. 2D Cine images were acquired in 3 short-axis views covering the aortic valve area from the left ventricular outflow tract to the ascending aorta at 6 mm intervals using a segmented steady-state pre-precession sequence. In 3D planimetry, 10 contiguous slices were obtained in a single breath hold perpendicular to the long axis of the ascending aorta in the aortic valve plane. The scout view for this acquisition was the mid-systolic phase image of the 3-chamber views in the MRI. The most stenotic portion of the aortic valve was targeted for images in the middle of the slab, corresponding to the mid-systolic phase. Transthoracic echocardiography was performed using commercially available equipment. The continuity equation was used to calculate AVA using the LVOT diameter, LVOT peak velocity measured by pulse wave Doppler, and the highest aortic valve continuous wave Doppler peak velocity obtained from apical or right peristoneal window. All scans were analyzed by 2 experienced observers who were blinded to all clinical information using commercial software. Image quality was assessed using a 4-point scale. Grades 3 and 4 indicated diagnostic quality. Representative examples of 3D planimetry reconstructed using commercial software. In A, volume rendering image shows the 3D structure of the aortic valve. In B to D, 2-directional cross-sectional images taken perpendicular to the aortic valve were used for reconstruction. Note that there is a high-velocity jet with high contrast. We measured the maximal area of the aortic valve at mid-systole. Figure shows a representative example of 2D planimetry for Cine MRI. We drew a line along the edge of the maximally open aortic valve on the Cine image. To compare the AVAs obtained by the 3DP and 2DP techniques with that obtained by TTE, we measured the intra-class correlation coefficients for the intra- and interobserver agreements. Bland-Altman plots were constructed to facilitate the assessment of the sources of disagreements. The qualities of the 2DP and 3DP images were compared using weighted kappa statistics, which adjusted the unweighted kappa for asymmetry of the two-way table for image quality rating data. The various ICCs and image qualities were compared using 2 sample t-tests, applying the central limit theorem for large samples. The clinical characteristics of the study population are summarized in Table 1. No differences were evident between the AS and control groups. Aortic valve replacement was performed in 105 of the 139 patients in the AS group. 2, 22, and 115 patients had mild, moderate, and severe AS respectively. The mean image quality for 3DP was higher than that for 2DP without statistical significance in the AS group. The mean 3D AVA results for each observer, Observer 1 and Observer 2, during the first and second assessments are shown in table. The mean AVAs according to the average of OB1 and OB2 in the AS group measured by 3DP, 2DP, and TTE were 0.81 centimeters squared, 0.82 centimeters squared, and 0.080 centimeters squared respectively, without significant difference among the 3. In total, 4 measurements were obtained for each method, and 3DP showed a higher degree of agreement with echocardiographic AVA than 2DP. The inter- and intra-observer agreements were excellent for all 3 groups. The agreement between AVA and echocardiography was lower for patients with ejection fractions of less than 40% than for those with higher ejection fractions with 3DP, but there was no significant difference in measurements between the 3DP and 2DP techniques. The Bland-Altman plot for the averages of the 2 measures versus the differences between the 2 measures indicated that there was no obvious trend in the 3D planimetry and TTE findings, as well as those of 2D planimetry and TTE. Figure shows a representative case with 2 separate orifices. The areas for the 2 orifices were measured twice and summed to calculate the valve area. The 3D planimetry image shows better contrast in the valve orifices than 2D image. Note the bicornuate appearance of the flow jet profile on the volume rendered image. In this case, there was moderate stenosis on transthoracic echocardiography with an AVA of 1.10 centimeters squared. The echocardiographic window was rather poor in this study. The AVA measured with 3D planimetry was 1.18 centimeters squared. The AVA measured with 2D planimetry was 1.48 centimeters squared. The peripheral and central parts of the AV orifice could not be measured in a single plane on CT. Oblique sagittal reformatted image and on-phase and profile navigation images of CT show a curved appearance of the AV orifice plane. The AVA was 1.29 centimeters squared on CT. In this patient, 3D planimetry correlated best with echocardiography for measuring AVA. The main advantage of the 3D method used in this study was that it allowed for comprehensive analysis of the aortic valve structure by providing 3D volume data for AVA. Moreover, 3DP performed within the duration of one breath hold reduces scan time and improves patient workflow, while it theoretically more accurately depicts AVA. The higher spatial resolution of the 3D technique with 2 mm slice thickness compared with that of the 2D technique may allow more reliable AVA measurements. The bright signal intensity due to high velocity turbulence around and above the jet flow in the aortic valve orifice enables the 3D appearance of the aortic valve jet flow profile to be visualized, facilitating the clear measurement of AVA because of the greater contrast between AVA and the surrounding aortic valve tissue. The use of 3DP is particularly beneficial when evaluating AS in patients with two separate orifices, several divided sections, or complex full velocity profiles. As for the limitations of this study, first, there was no gold standard comparison. Second, in our study, the image acquisition duration was 190 milliseconds, but to achieve a better temporal resolution, we needed a shorter acquisition time. Third, 3D echocardiography provides an accurate assessment of the AVA by providing the anatomy of the left ventricular outflow tract. However, we have used 2D echocardiography instead of 3D echocardiography. In conclusion, high-resolution 3D MR image acquisition with single breath hold SSFP sequences gave AVA measurement with low observer variability that correlated highly with those obtained by echocardiography. We propose that 3DP can be used to assess the severity of AS in clinical practice. Thank you for your attention.